Good evening, everyone, and welcome to our COVID-19 update. Ben and I have a lot of ground to cover, so we'll get right to it. So if I could have the next slide, please. So here's data, and COVID has always been about data. We're looking at some national and state numbers, USA and Florida. We're looking at the deaths and we're looking at the cases. And in between, you see the excess deaths. And we've talked about that in the past. And that represents the what is presumed to be or perceived to be by many to be the real number of deaths. And you'll notice it's considerably larger than the numbers that we have on the left. Having said that, I actually read something just today that was forwarded to me by Ben. And in fact, these numbers might even be low in terms of what the real death toll is. And not only does that apply to our country, but you can imagine what it might mean for the world when you especially have areas like India and China. Remember that to have a death by COVID, you need to have a positive test. And, there's areas of the world that just don't even have the testing to come close to that. Now, on the bottom of the slide, there's something about the long haulers. And again, there's a huge range of what people think may be a number, 10 to 30%. And I'd also like to point out that not only do we have death and long haulers, but we have all the morbidity that goes into people who spend weeks, if not months, in the hospital, in the ICU, on ventilators. They suffer almost semi-permanent or permanent damage to their organs. There's a lot of injury and a lot of bad outcomes short of death that can be associated with this virus. And it makes me a little bit upset when I still hear it referred to as just a cold. Next slide, please. So in Israel, they've been ahead of the curve with immunizing and getting vaccine data. And this is relatively new, as you can see by the date. And what they're showing here is simply that, unvaccinated people are getting sick, unvaccinated people are dying. And again, this is all in the face of a relatively low positivity rate, as you can see, 0.88. Right now in Sarasota, I just noticed today that we finally dipped down to 3. We were 4 for a couple of weeks and holding there. I'm guessing that back in June, we were under 1 as well. Things are better in Sarasota, but we still haven't quite hit the marks where we need to be. In fact, with our cases per 100,000 and our positivity rates, we're still considered to be in a high rate of COVID region by the CDC. And it's still recommended that people wear their masks indoors, and particularly in crowds. And that's if they're immunized. The recommendations for unimmunized people are much stricter at this point. Next slide, please. So this is Sarasota Memorial Hospital. This is where I lived for 34 years of my life. And, with all of our updates and all of our COVID meetings, I borrowed data from the hospital with their permission. A lot of it's online. Anyone can access it just by going SMH COVID. You can see how many patients are in the hospital and how many ICU beds there are. And, this is, I think, important because it what's going on in the world is important, what's going on in the country, state, et cetera. But this is what's going on right here in front of us. And if you go to the next slide, you'll see that what's happened during this past surge is extraordinary. Now, it's a kind of a busy slide, so let's just look at, if you go to the left, you'll see that all the curves kind of go up as we go into season. This is the amount of patients in the hospital. As you go into season, you go up, and then as you go down, as you go across, you come to summer, and with every year except this year, the numbers go way down. So I'll point out that 731 average census. I mean, Sarasota Memorial broke all their records this summer. Beds, ICU beds, it was extraordinary. And in fact, it was so extraordinary that it forced me out of retirement briefly. I've been retired for 2 years. On August 8th, which was exactly 2 years after my retirement, I was in touch with my former partners, as I had been through the pandemic and through the previous surges. And in fact, they weren't okay. They needed help. the hospital was taking in 30, 40, sometimes 50 new COVID patients a day. The ICU was up over 100 beds. The amount of work that had to be done on a daily basis was actually far beyond what could be done. We really had to go more to a triage system, taking in the new consults as they came. And what I saw, next slide, please, was that the numbers were dramatic. And what this slide does is it compares this surge to the surge we had last year. The dates are a little bit discordant, but approximately the same amount of time. And again, if you look at the daily admissions, if you look at the total hospitalizations, if you go right down the list, it's staggering what this surge did to the hospital and to our community. When this happens, surgery is shut down, elective surgery, that is. The emergency rooms get backed up. People are literally afraid to go to the hospital. And then you get into the whole idea of what happens to people who need other forms of healthcare. What happens to the patient that has chest pain? What happens to the patient that's having bleeding? It's a very bad situation, to say the least. And again, toward the bottom, you'll see that what was driving the surge, very clearly unvaccinated people. 86% compared to 14% of this whole milieu here was unvaccinated patients. Next slide, please. So let's talk about the vaccines, and we're going to talk about vaccination, and we're going to talk about booster. The breakthrough cases that we saw in the hospital represented a small proportion, and we're going to talk about that. But remember, the majority of people in the hospital are unvaccinated. So I can't help but to reach out to anyone out there who is still not vaccinated and is thinking about it. The vaccines have now been improved. Vaccination works. We didn't have this surge because of the persons or people who got vaccinated. We had the surge because of people who did not get vaccinated. And what we then enter, next slide, is the realm of vaccination versus boostering. And I think that from my standpoint, they're both important. We need to continue to vaccinate. The plus or minus 2/3 in our area is not enough. But we also need to consider the boosters. And we need to remember that the boosters do not imply a failure of the vaccine. Let's just go back and talk for a minute about what the vaccines did. Remember when the vaccines were in progress and we were waiting for them? If you remember, people estimated that perhaps we would get vaccines that were anywhere from 50 to 55 up to 70 or 75% active. And then lo and behold, Pfizer starts releasing their data, and then Moderna, and we have a vaccine that's 95%. So I think that we quickly forget that these vaccines started out much better than anyone could have anticipated. And so we went through the first part of our vaccinated life with these high levels of antibodies, although what we didn't know, and I don't think people could promise, would be how long these vaccines would last. And the idea of a booster was certainly always out there. And I think what's happened is that, with time, we've seen two things. One is we've seen the natural erosion of antibodies, and we've seen the emergence of the Delta variant. Now, let me just say one more thing about the vaccines themselves, which applies both to the vaccines and the boosters. They stimulate the immune system in many ways. One way is that they help the body to make these antibodies. And I like to think of the antibodies as the front door. And if the front door is closed, meaning you have adequate antibodies, the virus does not get into your body, into your system, and you don't get sick. So what's happened here, and all the numbers you hear and the data you hear, is that these antibody levels have dropped. And lo and behold, as the antibody levels drop, the virus gets into the system, and then people can get sick again. Now, again, going back to what I saw and what everyone else is seeing, the younger, healthier people, even with the dropping antibodies, seem to stay relatively healthy. But what about those vaccinated people that were older? Is there anything else we can do? Are they more than should be expected as time goes on? And that's where we need more data. Next slide. So
which slide are you on?
I'm on CDC.
Oh, okay. I went too far ahead. Okay.
Okay. Yeah. For those listening out there, I have some technical difficulties here, so we're kind of working out the best we can. Well, the CDC slide states that people over 65 account for 76% of the hospitalization, 85% of the deaths. Clearly, that's something that we need to be concerned about, and something that is we want to be better. Now, I did ask to remove slide 10, and so let's go to slide 11.
Which one is that? Pfizer data?
11 is Pfizer data.
Okay.
Okay, so again, always back to data. So Pfizer released this data, 10,000 fully vaccinated people, half receiving the booster and half receiving placebo. And what they're showing is that we can go back and recreate the wheel. Only 5 COVID-19 cases in the booster cohort, 109 in the placebo cohort. So what's happening here is they're showing that by boostering, they can re-achieve that level, that 95% type level. They can close the front doors on 95% of the people and kind of get us back to where we are. Now, I will say that there's a lot of positive feeling that in fact the boostering is super boostering the immune system, including helping us to hopefully maintain these antibodies for a longer period of time. But I don't know how anyone could know that without without a crystal ball. Next slide, please. So this is looking at some Israeli data. Again, and look at the date, New England Journal of Medicine. This is September 15th. Over a million people that are 60 years of older, showing that in fact, that when the people who were not boosted had a much higher infection rate. Now, again, critics would say that, well, what does infection mean? It could mean someone's asymptomatic. It can mean that someone has a quote unquote cold. Well, that's fine, but look at the next line. Rate of severe illness in non-booster group, almost 20 times higher. Severe illness implies at least need for oxygen. These are the people that enter the hospital. And then once you enter the hospital, then there's a cascade of people that will go on to the ICU and will go on to die. Next slide. More data from Israel, 750,000 people. And again, those who received the booster shot, 92% lower risk of COVID infection, but more importantly, 93% lower risk of hospitalization and an 81% lower risk of death. So next slide. We have finally here in our country, with the help of this data, the FDA and then the CDC approve the Pfizer and Moderna vaccines in this manner. Eligible for a booster, again, targeting 65 or older, targeting people in long-term care settings, underlying medical conditions, and that's a huge list. Any kind of chronic illness, heart, lung, kidney, brain, cancer, chemotherapy. It's not meant to be exclusive. It's meant to be very inclusive to anyone who really has any kind of a medical issue. And then you have people living and working in high-risk settings, and that will also account for our frontline workers. The booster is after 6 months, and you can mix and match, as I'm sure everyone has heard about. Next slide, please. Johnson & Johnson's story hasn't been as good, as we learned that we probably could have been boostering people as early as 2 months. But again, they're recommending that everyone who's had a Johnson & Johnson get a booster at this point, crossing the age barrier that the other ones have set up. At least for the time being. And I say for the time being because as time goes on and we get more data, I would say it's more likely than less likely that we will want younger and younger people to get vaccinated according to how their antibody levels drop. Again, the front door closing, and how their bodies respond to that. Meaning, are they getting sick? Are they getting hospitalized? Are they dying? And that's the ability of the body's other immune systems, T cell and B cell, that you may have heard about, that probably in the older population isn't holding up as well as the younger population. And as part of the reason, I say part of the reason why we're seeing the differences in age. So that really takes care of the vaccine pitch I wanted to make, both for immunization and boostering. My guess is that most of you listening tonight are at risk and are in the category that could get a booster, while the CDC officially considers you fully immunized if you've had your 2 Moderna, your 2 Pfizer, or your, now it's probably 2 J&J. I think it's fair to say that you're probably not as safe as you could be, and you're probably not as protected as you could be until you're boosted. So I think there's some semantics in play there. Who knows, maybe even some politics. But I think that, people need to get boosted if we're going to continue to let the vaccines provide the amazing positive response that we've seen so far. So in the last few minutes, I'm going to just switch over to cover some things that I've talked about before. Not a lot new, which is, again, another reason why the vaccines are so important. If we can go to the treatment slide, we'll go to the one outpatient. A couple of slides down, monoclonal antibody cocktails, Regeneron. If anything, we're using less. We don't use it in the hospital anymore. We've found that if you're in the hospital, it's essentially too late for that to work. So this is really more of an outpatient modality, and time is of the essence. So if you've been exposed and think you may have COVID-19, you need to get tested. And particularly if you have these risk factors, which are kind of the same as getting a booster, you need to find some Regeneron. You can try accessing through Sarasota Memorial Hospital. I don't know exactly where else it is now in the community, but they can point you in the right direction. The inpatient drugs haven't changed at all. Steroids, the remdesivir is the antiviral. The biological agents, we're probably using more of that than than when I last spoke to you all. These are the drugs that shut down the immune system at a point where the COVID-19 virus is causing a surge, as it's called, and lung damage. But you just don't want to be in the hospital in this situation. These people are sick, and a lot of them don't do very well. Next slide. Testing does not equal vaccination. So basically, if you go from state to state and locality to locality, and you look at how do you get into a restaurant or a movie theater or an opera theater, it's not all the same. There's different rules of engagement, and my point here is that vaccination, if you want to have the safest possible experience, if you own a venue and you have people coming into your venue and you want it to be the safest possible experience, then you want everyone to be vaccinated. Okay. The fact that a lot of places will offer the option of testing is, again, not to say that that's an equivalent. I think that's just the way it is. I mean, I think that I'm not trying to be political. It's politics. It's people have different opinions. It's complicated. What do you have a right to ask? What do you have a right to check? Does a person have a right not to be vaccinated? I mean, all these things go into allowing for the testing to be part of what might get you into a venue. But please don't confuse it as being equivalent. And the main reason why is because, if nothing else, I mean, there's too many tests out there with variable predictabilities, false positives, false negatives. There's problems with the actual testing, the operator, the interpretation, and there's also the lag time. This virus replicates so quickly that you can be incubating the virus in the morning, have a test done correctly, which is negative, and by that evening, if you had the test done again, it would be positive. And if you have tickets to the theater 2 or 3 days later, well, you can just imagine how many people can slip through the cracks in that scenario. Next slide. masks. Again, we've talked about masks, but not much has changed. N95s are superior. I think there's more and more data to support that. The CDC hasn't really changed its recommendation because they're still trying to preserve these masks for healthcare providers and frontline workers. But if you're flying, if you're going to an airport, you want to wear the best mask that you can get your hands on. And I think a lot of you have these N95s or KN95s or KN94s. I believe are from South Korea, and they are the best masks. Surgical masks are good, but they're not as good. Cloth masks can be very variable. And then at the bottom of the pile is the gaiters that people just pull up over their nose, and that's more cosmetics than anything else. Next slide. So remember, social distancing is still can be in vogue. Use your common sense in terms of your masking. It depends on who you're with, where you're going, what the crowds are like. I think we don't see enough of it anymore in places where we should. And there's still the little patches on the ground where you should be standing, but no one's paying any attention to it. And last but not least, never stop washing your hands. Ladies and gentlemen, that concludes my portion. I hope it wasn't too disjointed as I look at my phone and my computer, and not sure what you're seeing, but I'll turn it over to Ben.
Well, I'd like to start with this headline in the Journal of the American Medical Association in July of this year. It talks about COVID-19 beyond tomorrow. What are the potential end games for this pandemic? Is it eradication, elimination, cohabitation, or conflagration? I think that spectrum of options is going to depend on the number of variants that may or may not appear, and how we vaccinate and boost ourselves as we go forward, plus the potential for new treatments. And I'm going to hopefully excite you about the sciences coming down the turnpike in terms of new approaches towards vaccination and treatment. So I'll be briefly talking about the long haul syndrome, viral mutations, new vaccines, new treatments, new diagnostics, and management of the next pandemic if we have time to cover that. So the long haul syndrome, as Andy said, is 10 to 30% is the estimate, but it can be people who have had very mild disease. This is from the New England Journal of Medicine in August of this year, and estimated that 15 million people who have a long haul syndrome, and the average age is 40. This is a syndrome that lasts either for a few weeks or months, but can go on much longer and can be devastating for people. So you can have mild breakthrough disease and still have long haul syndrome. I'd like to share with you this very brief video clip on how viruses or why viruses mutate.
All viruses mutate at a particular rate. And since SARS-CoV-2 has been in the human population, there's been a detection of a couple of mutations every week or two in the virus. So seeing so many mutations in one virus was a real sort of bellwether to say, okay, something's going on here. The mutations are spread out along the entire genome. But when you look at a subset of the mutations, 3 of them appear in the spike protein. And that's important because the spike protein is the protein that the virus uses to attach to cells and get into cells. But it's also important because the spike protein is the antigen that we use in our vaccines. And any mutation in spike is always a concern because it may alter one of those 2 things. All the data suggest exactly that. The people who have been infected show symptoms that are consistent with the symptoms of any other lineage of SARS-CoV-2. So these may be mutations that make the virus more transmissible, but not more lethal or more disease-causing. But we do have to remember that when a virus becomes more transmissible, that means that it could generate more cases, and then more cases, even without a change in hospitalization rates or fatality rates, will mean more serious cases. So it's good that this virus isn't inducing more disease, but because it's spreading faster, it has the potential overall in a population to cause more severe cases. Right now, everything points to the fact that masks, physical distancing, avoiding crowds, all those things should still be working against this variant.
Okay, so classical thinking about variants is that they occur in people who are infected, so primarily the people who are unvaccinated. And as the virus changes and grows inside of somebody, it mutates, and therefore we get more variants. But there is an intriguing new theory about where the variants may come from, or some of the variants may come from, in the next slide.
All virus.
A UK man in his 70s was admitted to a hospital in Cambridge with COVID-19 pneumonia. He had first tested positive for SARS-CoV-2 a month prior. Throughout his hospitalization, the patient continued to test positive with a high viral load. This, along with his worsening illness, indicated that he was battling an ongoing infection with live replicating virus for more than 100 days. His body wasn't equipped for the task. Back in 2012, he had been diagnosed with marginal B-cell lymphoma. The blood cancer, along with the treatment he received for it, had wiped out his B and T cells, both arms of his adaptive immune response, leaving him severely immunocompromised.
The case report describing this patient's infection and treatment was published in the journal Nature. It's part of a growing number demonstrating that some infected patients with severely weakened immune systems can take months to clear COVID-19, if they ever do. And virologists worry that their prolonged infections and certain therapies can provide the time and the evolutionary pressure for variants to emerge.
So what this video clip shows is that
each virus has an
is a real concern about the people who have immunocompromised situations, get infected, and then who are partially treated with immunologics or other medications, that they can be the reservoir that creates many new variants. A really disturbing video clip. What about vaccines? So at the moment we have only injectable vaccines, but if you think about trying to vaccinate the world and the shortage of needles and syringes and the reuse of needles, syringes already causing a scare of HIV in third world countries, alternatives to needles for vaccinating people would be wonderful. So the first one is an intranasal vaccine that is undergoing testing as we speak. As you know, that oral vaccines have been used for polio for some time, so the technology is not that different. Oral vaccine, there's one under emergency use authorization. It's called Vaxart. It's an oral tablet, and it's currently undergoing a phase 2 and about to start a phase 3 trial. Now, this is a subject that may, I apologize if I lose some people here, but when you talk about the mRNA vaccines, the mRNA in a vaccine is a very small component, and it's surrounded by what's called adjuvants, which stimulate the immune system, and nanoparticles, which allow it to spread around the body. And that's what makes the difference between the Moderna and the Pfizer mRNA vaccines. So there's a lot of research going on in trying to improve the adjuvants and the nanoparticles without changing the amount of our mRNA that we need. And there's some examples, Capricor Therapeutics and Kodiak Biosciences are two very interesting biotechnology firms that are working on improving adjuvants and nanoparticles. What about monoclonal antibodies? We heard from Andy about Eli Lilly and Regeneron. But there's a new one on the horizon, which is undergoing FDA approval, called Sotrovimab, which results in an 85% reduction in the risk of hospitalization or death, far more effective than Eli Lilly or Regeneron's, and it's currently in a phase 3 and can probably be given later than the Regeneron. In other words, when somebody's already admitted to hospital, they could be given this monoclonal antibody cocktail. There's an announcement that occurred just a couple of months ago in the Journal American Medical Association called Uber antibodies. And so very cleverly, people have looked at, scientists have looked at the antibodies that were produced when the original COVID pandemic occurred. And then they can separate out these antibodies in multiple different kinds. And they've done the same with Delta variant. And they are now being able to manufacture those specific antibodies that arise in people who recover and manufacture them in large quantities, which spurs new therapeutics and vaccines. But I love the title, Uber Antibodies from recovered COVID-19. But stay tuned, this is going to be a very interesting area of new therapeutics. The Weizmann Institute in Israel, with the Pasteur Institute in France and the NIH, have come up with a molecular supercork. So as you know, the vaccines head for the spikes on the protein, on the virus, and it's the spikes that attach to receptors on the surface, which then allow them to attach. What would happen if we could put in a supercork to prevent those spikes getting even anywhere near the receptors? It's a very simplistic way of doing it, and it could be done by an inhaler. So in other words, somebody who's is being exposed, or somebody has a mild disease, would use this inhaler and the supercork to be able to deal with it. Apparently, according to everything that I've read, this triumvirate with Weizmann, Pasteur Institute, and NIH have really come up trumps in terms of the new approach. And watch out for and keep your eyes peeled for new inhalers. This one just received FDA approval, and it's called Molnupiravir. And if you want to know why, I always can never understand why pharmaceuticals companies choose such crazy names for drugs. And when you get to my age, it gets increasingly harder to remember the names of the drugs. But this one is named after Thor's hammer, if you can believe it. And risk of hospitalization or death reduced by approximately 50%. So again, it will be somebody who shows up in the doctor's office, has been exposed, has early onset of the symptoms, and takes these medications for 2 weeks and has a 50% reduction in death rate. We all know that it takes 24 to 48 hours to get a COVID PCR test. They are antigen tests, but the one which is the gold standard is the PCR test. But as a result of work going on at the University of California in Berkeley by Rick Zhu et al., they have come up using this device, which recently won the Nobel Prize, called CRISPR, which is gene editing, to be able to provide very rapid assays for PCR tests. And again, stay tuned. This should become available at the beginning of next year. Let me wrap up because I want to leave plenty of time for questions. And the question is, how do we prevent the next pandemic? And Eric Lander is the director of White House Office of Science and Technology and Policy. And I've taken from his work what I think is the key issues. Design and test and improve safe, effective vaccines. We now have the technology. Once a virus is identified, we don't even have to have the actual virus. All we need to know is the sequence, that we can manufacture vaccines less than 100 days. And with factories that are able to switch very rapidly is really the key here. Simpler and cheaper diagnostics, as we discussed, international early warning systems, which will require greater collaboration across the world, which clearly did not happen this past go-round, strengthen our public health system, and coordinate with international partners. This one I would like to emphasize, which is in 2019, in the United States, we spent $3.8 trillion on healthcare, or 17.7% of our gross domestic product. For public health, we only spent $93.5 billion, that's it. Since 2010, states' public health funding declined 16%, and by local health departments by 18%, which explains, I think, in some ways, why we were totally unprepared for this pandemic. More than 3/4 of Americans live in states spend less than $100 per person annually on public health. 3/4 of all Americans. In fiscal year 2017, the budget for the CDC was $7.1 billion, or $22 per person, adjusted for inflation. CDC's core budget has been flat for the last decade. So we need to increase federal, state, and local public health budgets. we spend on healthcare twice the average of any other country, yet we have the lowest life expectancy, highest suicide rates, highest chronic disease burden, and obesity rates that are 2 times higher than other OECD countries. We have the highest number of hospitalizations from preventable causes and the highest rate for avoidable deaths, despite spending so much money, and challenges including global warming, bioterrorism, healthcare quality, population aging, healthcare financing, and on, chronic diseases such as diabetes. We need to address these complex issues with closer collaboration between public health and clinical medicine. I wear a hat in public health and in clinical medicine, but there are too few physicians who do that, and that makes it problematic because we're not going to prevent the future chronic diseases we're looking at without closer collaboration. With that, I open up for questions. I'm going to stop sharing and we can see each other.
Excellent. Thank you both for, and I know it's hard for you to put all this data into, to package it so that, we laypersons can digest it, but you certainly do a great job of it. So I'm going to read from the chat first. And the first question I see is if a person had COVID-19, do they have any immunity?
So this is a complex question, and I think that the evidence shows that you have some immunity, but the immunity you have from a natural infection is not as good as from vaccination. Hence the strong recommendation that people who are infected get fully vaccinated. And particularly if the infection occurred early on with the Alpha variant, then I think it's especially the case you should get vaccinated. But even if you got the Delta variant, you should get vaccinated.
Okay. Dr. Isaac Calvaria has a question which I hesitate to read. So Dr. Calvaria, if you would please unmute and ask your question. Is he, wait a minute, I'm looking around the screen. Is Dr. Calvaria still there? Oh yeah, there you are. Dr. Calvaria, could you unmute and ask your question, or do you want me to read it? Okay, here I go. There is data correlating vitamin D level to mortality, even going as far as suggesting that a vitamin D level of, and I hope I'm reading this right, 50 nanograms per milliliter is associated with an almost negligible mortality from COVID. Why has the simple, safe strategy of vitamin D level normalization received so little attention?
And
then he gave a reference. But
yeah, I mean, I don't have an answer for that. So
all right. Those are the only questions in chat. If anyone has a question, please raise your hand. Whoops, go ahead.
Take that on. I mean, I think that there have been a number of suggested perfect treatments for COVID, including hydroxychloroquine, ivermectin, vitamin D, and because there's one reference showing that it was effective, you have to do very large randomized controlled clinical trials to show that it truly does work. There are also some dangers to very high vitamin D levels, so it shouldn't be taken lightly.
Okay, thank you. Esme Ferber.
A question for vaccinated people who associate with unvaccinated people. Why do the vaccinated people carry the virus and infect other people?
So, okay, so what has happened again, as you're vaccinated and you start out with this high level of antibodies, over time, those levels drop. Remember, I'm going to call those antibody levels your front door. And let's see, somewhere around the late spring, early summer, we've at least, in this country felt that that immunized people, with these high levels that they started with, in fact, were not transmitting the virus. And if you can remember, there was a very all but 2 brief moment in time when we were told we could move freely about the cabin, we could take our masks off. And that did not last very long and was followed by this surge attributed to Delta. So again, as the antibodies drop, the front doors open. That's how a person who is immunized can then become infected. Infected, doesn't mean necessarily sick. It means that you've now acquired the virus. Now, for most people, the B and T cell immunity that they have, that the immunization has stimulated, that will continue to protect you from hospitalization and deaths. Again, in most cases, but not all cases. But the virus still gets in, and if it gets in, it can be passed from person to person. So over time, with waning immunity, opening of the front door, and the markedly increased amount of virus that the Delta virus variant spreads around, and the rapid rate that it multiplies, we got back to a situation where even immunized people could be contagious. Now, theoretically, with boostering, we can hopefully get back to that situation where front doors are now closed and properly boosted people no longer can be a vector for the virus. But I think we need more time and more data to prove that. Did that answer your question?
Yes, partly. So what levels of antibodies should one have? I guess we don't know that the level of antibodies.
Yeah, I think that one of the things that I've seen written a lot about is, given our experience now in the past, let's say 3 months, with the surge, with the emergence of the Delta variant, and now going through the surge and coming out into this age of boostering. I mean, what is the role of monitoring antibody levels? And I don't know the answer. Again, there's a lot of tests, probably too many, instead of developing just a few that work well. And I don't know that anyone knows how frequently they need to be done, or what level exactly we should be shooting for. Presumably, what we're told is that these boosters significantly augment those levels to well more than what's necessary to protect one. Did you want to add something, Ben?
Yeah, I would just say, because I'm part of the Moderna trial, and that's partly what's going on is, aside from measuring my antibodies, they're measuring my T cells, B cells, and a whole bunch of other cells. And they take gallons of my blood every couple of months. And at this point in time, they really don't know which one of these assays is the best. That's point number one. Number two is that they're not commercially available, these other tests. They're only available in research laboratories or large pharma. So I think to answer the question, Esme, we don't know yet.
So there's another question. Thank you, Esme. There's another question in chat, but before I get to that, so we know that the vast majority of Americans are vaccinated and probably going for their boosters. And now, of course, the 5 to 11-year-olds have been approved for vaccination. But we also know that there is a significant percentage, a significant portion of our population who, for whatever reason, fear, politics, stupidity, whatever, simply refuse. And I don't know if I don't know what we can say to those people to get them to get off their positions. So assuming that, let's say 15% of our population simply stay that way, I don't even know if you can answer this. How do we get back to normal?
Well, I think it's. I think you're asking the question. I started my first slide, which was, what's the future? I think it will depend on the development of new variants, and it will depend on how careful we are and whether we continue with masking and social distancing and try and vaccinate our children. So I think that there are approaches, but nobody really knows the answer to that in terms of when we will entirely be able to get back to normal. My hunch is that we are going to be very cautious over the next few years.
It's the safety to have in the restaurant after the booster.
I'm sorry, what?
Let me, yeah, go ahead.
So I just think that we're going to be cautious over the next few years, and it's going to depend on all of those variables.
Okay, it's an almost unanswerable question. I thought it might be, but I appreciate you trying. There's another question in chat. Are we going to have to take a booster every 6 months for the time being?
Andy, do you want to take that one?
Well, yeah, I mean, my answer would be that I don't think we know that yet. I really think that I don't think that that anyone knows that. I think that, again, I referred once to a crystal ball. I've read references to the fact that for whatever reasons, because they believe that these boosters are actually supercharging the immune system as opposed to just boosting it, that perhaps the time to the next booster could be longer. Ben, do you have anything to add to that?
No, I think, again, it depends on the emergence of a new and more dangerous variant will change anybody's schedule in terms of vaccines. The other thing is, I'm really hopeful that either the nasal or the oral vaccine will become the prime method for vaccinating people.
Okay, thank you. And Dr. Calvaria, I do see your hand up, but let me just read this one more question from chat, and we'll come to you. Is it safe to eat out in a restaurant after the booster?
Only if you take me with you.
All right, Dr. Calvaria.
Yes, I asked the vitamin D question. I couldn't find myself in the gallery to unmute myself. So just about the vitamin D, I think that the data is very, very strong, and it's a simple, safe treatment to raise vitamin D levels. You would think in Florida, most of us have normal vitamin D levels. That's not the case. My level was 25, and I had trouble getting it up to 40. I have never seen toxic levels of vitamin D, so I do think it's safe with frequent monitoring of levels. The other question I had is you didn't, neither of you said very much about the VAERS data, the morbidity and mortality from the vaccines. Now, I'm a very strong proponent of the vaccine, and I try to talk my anti-vaxxers into getting the vaccine, but they always throw this back at me. What about the dangers of the vaccine? What do we say to them?
Andy, do you want to take that?
I'd say the dangers of the virus far outweigh the dangers of the vaccine.
I mean, if you consider that the mRNA vaccines have been given to over 300 million doses, and the number of serious side effects has been, very, very small. This is probably the best tested drug we've ever had. And as Andy said, the risk of the disease is far greater than the risk of the vaccine, and the vaccine is proving to be incredibly safe. There isn't a drug. I mean, you won't know as well as I do. There isn't a drug, medication, or treatment that doesn't have some side effects. But this one turns out to have remarkably few side effects, and has been tested in so many people. So I would stand up and say this is a very safe vaccine.
I do agree with you, but the people that I struggle with are those who say that they have no risk factors. Well, they're over 65, so they do have that risk factor. But they always say, well, I have no risk factors. Why should I take this? But I completely agree with your argument, and I keep making it, unfortunately, without too much success in some people.
Isaac, it's so frustrating. And again, after spending 6 weeks back in the hospital, I mean, frustration doesn't even begin to describe my feelings. I took care of all these unvaccinated people, their patients. I treated them, with dignity and respect, but I just had to wonder, how they all got to this place. I mean, and a lot of young, nice people, wives, kids at home, good jobs, just didn't make any sense. And although not the majority of that group died, they were all in the hospital, most of them for 2 to 3 weeks, high flow oxygen. Not sure that a lot of them will ever be the same. And some of them did go on to die. And it's just, I just don't know what to say.
I'll give you 2 words: social media.
Yep.
I agree with you.
Yep.
Unfortunately, and as we all know, we each individually react to different treatments and medications in our own individual way. As an example, when Felicia and I got the boosters a little over a month ago, I had zero. I was expecting some kind of reaction, and I had nothing, period, nothing. Felicia, on the other hand, and this was explained to her by our PCP, had apparently it affected her lymph nodes, and she had very painful lumps that appeared on her chest that, was very, very concerning, but they simply disappeared after a couple of weeks, and it was as if it was never there. So everybody reacts differently. Do I see any questions? Okay, I see Ted. Go.
Well, I'll comment first on yours. I hope you at least had a sore arm, because if you did not, you might not be getting a response to the vaccine.
Oh, of course I had a sore arm, but
Okay, good.
That's from any
Glad
shot.
to hear that.
That's from
That
any
is,
shot.
no, this is, and that was what my original comment was about. People who do have immune suppression problems are being advised that to have their antibody levels checked. And the other thing is that if you have an immune problem, as my wife does, she has been advised that even though she's had a booster, she has been advised 6 months later to get another booster because of immune. Her problem is she takes a medication that suppresses her immunity.
Yeah, that's very reasonable, Ted. I mean, I think that one thing that Ben and I have discussed, and we've talked at the COVID task force meeting, and we're trying to get this word out actually through the newsletter and even the pulpit. We want everyone to go back to their physicians and discuss their cases individually, and not try to take their cue from a 45-minute talk for sure. Unfortunately, there's a group of people who you can give them a shot every month. They're not gonna mount an antibody response. And then on the other extreme, you have someone who, with a couple of shots, they could be good for years. And then everything in between. And clearly, those of us who are older and have medical issues, and particularly issues that affect or take drugs that affect our immune system, I totally support being aggressive with checking antibodies and not being afraid to. I mean, again, 6 months is a little. Maybe they'll find that she needs it before that. There's something magical about 6 months. It's just where the data fell out this time around.
All right, and we have time for one or two more. The person who is not Judy Sokol.
That's me.
Yep.
I know I don't look like Judy Sokol, but I'm here with Judy Sokol. And I had COVID approximately a year ago today, and I had a severe case of it. And since then, I've had both boosters, both shots, both Moderna shots. I haven't had my booster yet. I lost my sense of smell, and I still don't have it back. Is there any way of bringing back my sense of smell? I mean, it's totally gone. I cannot smell anything. No matter how hard I try, I can get fresh horseradish, as an example, right up my nose. And all it does is irritate it, but I don't smell
I
You want to take that?
Well, I don't know of any treatment for that. This whole pandemic is just now turning towards its 2-year birthday, whether you consider November, December, January, or February, or March. I just don't know that we know what to expect from these symptoms. That's what was one of the points I was making earlier, that a self-limited long haul type syndrome is one thing, but there's going to be a lot of people that are going to pay the price more than that over time. I guess it might not be unreasonable to again talk to your physician and maybe consider an ENT evaluation, but more than likely it's just from the COVID, and I don't think anyone has any treatment to bring that back.
So there are no new treatments, but there's a huge amount of research, collaboration between MIT and Harvard. At the moment, I was reading an article where these basic scientists are trying to use the loss of smell in the COVID as a response to COVID to try and better understand this sense. We know a lot about seeing and hearing, But we know so little about the sense of smell. And actually smell obviously affects your taste buds as well. But there is a concentration of researchers at Harvard and MIT who are looking at this subject as we speak.
All right, so it is 8 o'clock. I think I'll see if there's one more question. Does anyone want to raise your hand? By the way, there are a whole bunch of blank screens. So if you've got your hand up, or if you didn't use the little raising hand icon and you want to ask a question, just unmute and ask your question. Going once, going twice. Right, well, in that case, doctors, as always, we appreciate everything you do for us. Certainly, these updates are very valuable, and just thank you. Just thank you very much. And to everyone, please stay healthy, stay well, stay safe, and we'll see you soon. We'll see you soon. Good night, all.
Bye-bye. Thank you.
Good night. Good night. Thank you all. Thank you.
Good night, everybody.
Good
Yes,
night.
thank you both very
night.
much. You've done
Thank you,
a
everyone.
number of these, and
Thank you.
they've been incredibly valuable for all of our congregants.
Thank you.
Thank you all.
Bye-bye.
Appreciate it.